Hello, my name is Tiziano Barbui. I am speaking from Bergamo, and today I want to update you about the studies we are doing on COVID-19 in patients with myeloproliferative neoplasms. Let me start by doing a background for this. The background is the risk of infections in patients with myeloproliferative neoplasms. Recently, a study has been published by the Swedish investigators. This is a population-based matched cohort study done in Sweden. In Sweden, they had more than 8,000 patients with MPN in a registry, and they compared the outcome in terms of infection of these patients versus 32,000 controls. What they found is that the hazard ratio for any infection is the double higher than in patients without MPN. And among bacterial and viral infections, the hazard ratio was 2 and 2.1 respectively. What was important to know is that also here, the higher rate of primary infections, the infections, viral and bacterial infection, was seen in patients with myelofibrosis. But it was significantly more elevated also in ET and in PV as well. The second message from this study, very important message that we have to consider during COVID, is the effect of treatments of these patients. Patients were diagnosed between 2006 to 2013, and they had a follow-up until 2015. What they found was that hydroxyurea interferon anagrelide did not enhance the risk of infection as compared with those without any cytoreductive treatment. However, those patients who were treated with ruxolitinib for myelofibrosis, they had a 4-fold higher risk of infection, and this was highly significant. So, myelofibrosis is particularly vulnerable to infections also outside COVID disease. During the SARS-CoV-2 infection, the study I'm going to present you now was a study done by ELN, and we coordinated this study. And we collected a patient from Italy, Spain, France, Germany, and the UK during the first wave of infection that started in February to May 2020. What we found is, first, the number of patients with COVID-19 was more frequent. Patients were particularly those with myelofibrosis. More than 50%, 60% were with myelofibrosis, and the rest was distributed between ET and polycythemia vera. These patients had a survival, very short survival, because the mortality was 25% during the first month. It reaches about 30% after 60 days of hospitalization. And the mortality was particularly elevated in myelofibrosis. 50% of these who died were patients with myelofibrosis. And we did a multivariable analysis to see also the influence of severity of this disease, the COVID disease, and the role of comorbidities and the role of the drugs used during COVID. I mean the MPN drugs. And we found that the age and the sex, male, were independently associated with the mortality, as it was patients admitted to intensive care unit indicating more severe disease, the mortality is higher. But what is important to know for patients with MPN is that those who, for several reasons, discontinued ruxolitinib during the acute phase had a high hazard ratio to die. So many times more than patients treated with hydroxyurea or other drugs. And the discontinuation of ruxolitinib then was a factor that both in multivariable analysis and in the propensity score analysis was highly significant for mortality. So the message from this study is that patients on ruxolitinib presenting at COVID while treated with ruxolitinib, they should not stop ruxolitinib during the acute phase. This is easy to explain because the ruxolitinib has a role as an anti-inflammatory drug. And you know that the inflammation, pneumonia, and other types of inflammation in several parts of the body, including thrombosis and other peculiar symptoms due to inflammation can enhance the mortality. So ruxolitinib can reduce inflammation and in this way can reduce mortality during COVID. There are studies also documenting that ruxolitinib during COVID, the infection, the acute phase of the infection can reduce the mortality also in non-MPN patients with COVID disease. But another point that we have to consider is that ruxolitinib decreases also the immunity of these patients. And this immunity is particularly important to be considered in patients with MPN because they have an intrinsic dysregulation of the immunity, particularly in PMF. And this can account not only for more infections, but also for some considerations in vaccination of patients with MPN. Vaccines, you know, we have several types of vaccines today. We have Pfizer, RNA, We have Moderna, DNA vaccines. We have Johnson & Johnson, viral vectors vaccine. They use the spike protein as an antigen to elicit the onset of antibodies against the virus. We have also some vaccines using inactivated or live attenuated virus or subunit spike protein. So the question is, might some MPN patients not respond to these vaccines? As I said, immunity is altered in patients with MPN. And we don't know whether the impairment of T cells, CD4, natural killer, or B cells can be responsible of not responding patients to vaccines. Another point that we have to consider is whether the JAK2 inhibitors can reduce also the vaccine power in these patients. So that we have to do studies on that. And this is why our study is going on, still going on now, because we have asked our center and also other centers to join us, to document and to confirm whether the higher incidence in myelofibrosis, incidence of mortality, is confirmed, higher mortality following discontinuation of ruxolitinib can be demonstrated again in a larger series of patients. If we have also a greater thrombotic risk in patients with essential thrombocythemia, we published a paper on that. And we want also to describe the clinical epidemiology in the third wave of infection, especially now we are facing with variants of the virus, and to report also post-COVID sequelae. This is an important field for MPN patients because they are more vulnerable also to the sequelae, maybe after recovery from COVID-19. And of course, we want to monitor the results obtained with the COVID-19 vaccines.